Hello, everyone. I'm Ankita Shah. I'm a nurse practitioner and access partnership consultant at the NMDP. On behalf of Blood Cancer United, formerly known as the Leukemia Lymphoma Society and NMDP, we welcome you to Project ECHO Session 3 on treating acute leukemias, coordinated care from treatment to survivorship. This is Blood Cancer United and NMDP's third Project ECHO session, and we are so excited to be with you today. If you have participated in a Project ECHO session before, please go ahead and share an emoji reaction now. Great, I'm seeing some come through. Awesome. Okay, so to kick us off, I think I'll ask each of our speakers to introduce themselves. So why don't we start with Dr. Holtan with a brief introduction.
Hi, I'm Shernan Holtan. I'm the Chief of Blood and Marrow Transplant at Roswell Park Comprehensive Cancer Center in Buffalo, New York. Go Bills.
Awesome. Dr. Loren?
Hi, everybody. I'm Alison Loren. I'm the Director of Blood and Marrow Transplant and the Division Chief of Hematology-Oncology at the University of Pennsylvania. I would say go Birds, but we've already embarrassed ourselves this season, so I will bow out on that.
Dr. Alsfeld?
I'm Clark Alsfeld. I'm a transplant leukemia and transplant physician at Ochsner, MD Anderson in New Orleans, Louisiana. I'd say who dat, but I don't know if we've made it that far in many years, so I'll also stay out of it.
I love it. And Dr. Bellomo?
Hi, I'm Dr. Bellomo. I'm a hematologist and the director of our autologous stem cell transplant program at New York Oncology Hematology, a private practice in Albany. And I'm going to, I guess, just echo Go Bills. So
I love it. Thank you all. So I think we're going to get started with our learning objectives, which are about to pop up on our screen here. So we will be recording this session and we'll post it on the NMDP and Blood Cancer United sites in the next few weeks. If you do not want your video to be part of the recording, please feel free to keep your camera off by using the black menu bar on the bottom of your screen to turn it off. But otherwise, we would love if everybody could have their cameras on and have this really be a community feeling. Remember, please don't share personally identifiable health information about any patient during any discussion today. We ask that you make sure your first name, last name, and the organization are included in your name so we know who is participating, all part of really this community feeling. And we put instructions on how to do that in the chat. We do encourage your questions and comments, so feel free to type questions in the chat. And during the Q&A portion, use the blank menu bar on the bottom of the screen to raise your hand, and the moderator will call on you. If you are dialing in to participate in the Q&A, just use *6 to mute and unmute your line. So the Project ECHO model is really designed to create a shared learning space for healthcare professionals through a series of educational sessions, fostering peer engagement and disseminating best practices in community care. This is session 3 of a 3-part series. Sessions 1 and 2 can be found on both the Blood Cancer United and NMDP websites on our healthcare professional resources and continuing education pages by searching ECHO. All are interactive, all teach, all learn opportunities. And the primary goal of the ECHO model is to efficiently disseminate evidence-based strategies by leveraging a one-to-many approach so each ECHO participant can take what they learned back to their teams and their communities. In the spirit of ECHO, we ask that you have fun with this. You use this space to learn and collaborate with one another, be present, and inevitably, we will roll with the IT punches if there are issues that arise. We'll focus on patient cases for this talk today, which are introduced in earlier sessions and will be concluded today. So we'll start with some polling questions, and your responses here would be greatly appreciated. So let's have our first question. What is your practice setting? And you could select all that apply here. Awesome. Thank you guys for your input. It looks like there's kind of a split audience here today between all of the different groups. So excited to have a great discussion today. Wonderful. So now I'll kick it off to Dr. Holtan for our first case.
Thank you so much, Ankita. I'm excited to conclude this AML case study with you. If you've been with us for previous ECHO sessions, you've heard about this patient already. This is based upon a real patient of mine. Very challenging case that poses a lot of good questions for discussion, I think. So let's just kind of refresh where we were with this case. This is a gentleman who in the 1990s had marginal zone lymphoma. and in the 2000s had a transformation to diffuse large B-cell lymphoma. He was treated with radioimmunotherapy at that time and had been in remission from his lymphoma for over 2 decades. Then in 2022, he's in his 70s. He develops pancytopenia, and a bone marrow biopsy showed AML with TP53 mutation and complex cytogenetics. So obviously a very high risk, likely therapy-related AML. He underwent induction chemotherapy with azacitidine and venetoclax, and amazingly achieved a molecular complete remission. However, his course was quite complicated during his induction chemotherapy. He had prolonged pancytopenia that ended up resulting in an aspergillus pneumonia. This was a really aggressive pneumonia requiring a prolonged hospitalization and exposure to pretty toxic agents, including amphotericin B. But we got him through that. He was in remission. His fungal pneumonia was controlled, and he proceeded to a fully matched unrelated donor peripheral blood stem cell transplant. We conditioned him with reduced intensity conditioning with fludarabine, cyclophosphamide, and total body irradiation, 200 centigrade. And his GVHD prophylaxis was with post-transplant cyclophosphamide, tacrolimus, and MMF. Next. So early in his course, he developed some complications that were challenging. As early as day 18, right around the time of engraftment, he developed profuse diarrhea and confusion. Stool, blood, and CSF were all PCR positive for adenovirus. So systemic adenovirus, very challenging, very early in his transplant course. He was treated with cidofovir. It took weeks and weeks for the virus to clear. His diarrhea lingered for a couple of months. And when I mean diarrhea, I'm talking liters a day, 15 diarrheal bowel movements. This was a massive set of side effects that was really difficult to handle. And he was hospitalized for quite some time. During this time, of course, we're questioning, could he have developed graft versus host disease? This is always a challenge when you've got symptoms that are consistent with graft versus host disease, but you can't always rely on biopsies. They can be inconclusive, especially in the setting of infectious colitis. What we were learning from the PT-Cy story was that the risk of graft versus host disease is actually very low with PT-Cy. His absolute lymphocyte count was very low. Again, he had a full match donor. The risk of severe graft versus host disease is so low, as less than 5%, that we actually thought all of his symptoms were related to adenovirus. But we were able to look at some biomarkers to help with this clinical judgment. And I want to share a little bit with you about that on the next slide. So, of course, when I was a fellow, and even early in my career, this patient would have been evaluated for adenovirus. Of course, we would treat that, but we would be stuck trying to figure out if they also had developed graft versus host disease in addition, especially when the biopsies are suggestive of it. But we're developing some tools to help us sort out whether someone has really just an infection that's driving their complications or their symptoms versus graft versus host disease. That biomarker that we've developed at Minnesota should hopefully be widely available through ViroCore soon, called amphiregulin. This is a marker that is increased in the blood during graft versus host disease, but we've shown that it's not so elevated during infectious colitis. And in fact, we'll have a poster on this at the upcoming tandem meetings next week. So our field is improving to the point where we're fortunately getting some tools to sort out some of these difficult clinical conundrums. So in this patient, we were able to measure amphiregulin levels. They stayed low. We never gave him treatment for graft versus host disease, so we were able to avoid systemic immunosuppression. And eventually, he did improve with just clinical care of his adenovirus and extensive supportive care. So he was able to fully recover and make it out of the hospital. Next. It was not an easy course. He was in the hospital, pancytopenic for about 4 months. Even when he was out, as you know, after a transplant, if you have something massively inflammatory happen, you can be pancytopenic for a while. So he needed transfusions and and GCSF for quite some time as he was recovering. In addition to adenovirus, he also had COVID-19, he had rhinovirus, he had an E. coli UTI, and CMV viremia, all of which we had to treat. Now, this is kind of emblematic of what can sometimes happen after a transplant, especially in the PTCy era. We know that there is an increased risk of infections after PTCy compared to calcineurin inhibitor and methotrexate-based GVHD prophylaxis. It's still worth it though, because it's not an increase in fatal infections. We have to deal with them, but most of the time we can overcome them. And the benefit we get is very low rates of severe graft versus host disease. So this patient shows, yeah, there's a lot of infections. It can be challenging for some, but we can get through it and then avoid graft versus host disease. So just with supportive care, he continued to recover. Next. So where he landed at day 100, he was in remission. When his counts improved, we started hypomethylating agent maintenance for 2 years. Think back, this is AML with TP53 mutation and complex cytogenetics, really nasty AML. We were able to give him maintenance. He is well past 2 years post-allo transplant now. He's in continued remission. He has not been back in the hospital with no further infections. He's completely back to living his life, doing things that frankly I think are slightly dangerous for normal people, but he's kind of an adventurous person. He's back to living his life, got through all of this, and he's one of my favorite patients. I want to just share this very difficult case so that we don't have nihilism over very difficult AML and sometimes very prolonged hospital course with a lot of complications. If we hang in there with patients, sometimes we can get through some pretty tough stuff. So he is truly very resilient, and certainly this type of patient, had I seen him in my fellowship, he might not have gotten a transplant. But nowadays, with better supportive care, better graft versus host disease prophylaxis, better ability to distinguish GVHD versus infections, we can get through a lot more complicated stuff these days and have good outcomes. Next. So challenges this case illustrates in real life. Do we even transplant TP53 mutated AML? I know some centers don't, but we need to really talk about this as a community. What infections would exclude someone from a transplant? I know what it used to be, but now that we have such better therapy and monitoring, we have to have that conversation. Post-transplant toxicities. What is graft versus host disease? What is infection? It is challenging. In the PTCy era, we're almost always dealing with infections more than GVHD, but we still have to be vigilant. And then the role of maintenance therapies is still a huge controversy, especially if you don't have a targetable mutation. We'll be talking about that later in this session as well. We know that the results of clinical trials are heterogeneous. We have a meta-analysis that shows a survival benefit with HMA, but how do we balance aggregate data versus individual benefit? This case just highlights a whole lot of challenges, but I'm happy to report the outcome was excellent for this individual. Next. So with that, I'm going to hand it over to Dr. Bellomo to ask some questions and engage in some discussion.
Thank you so much. So I think, this polling question is very obvious to me that we're going to pick this patient back up into the community. And so we'd just like to know from you, what sort of things are you capable doing at your practice? Great. Looks like, 3/4 can handle maybe everything but allogeneic and a slightly less percentage for that. Next slide. And then this really asking what's your preferred about allogeneic transplant. Excellent. Great to know that shared care with both teams. Next slide. So I'm really going to focus on, I think, the community perspective and talk a little bit about shared care. How do you make sure that you're ready to accept these patients? And if you're at an academic center, how do you start to feel comfortable bringing patients back locally? I think really what it comes down to is communication and then bridging that into trust between your community partners and your academic sites. And so I think as a community provider, the first thing that I think you need to do is look into really and be honest with what are you capable of, and be okay to say that you're not capable being like the academic center. I think that happens with turnaround times, laboratory studies. what medications you can give at your local hospital if somebody's admitted. What does it look like for your network there? Do they actually know what they're looking for if they're doing biopsies on graft versus host disease? Do you have an infectious disease specialist, a pulmonologist, a cardiologist who knows what they're looking for in post-transplant complications? Can you get skin biopsies easily? And I think about being honest about those things and really saying, hey, I remember an example where they were like, we're sending her back to you. It's Sunday. Can you flush her on a Sunday? Where I had to be like, no, we're not open. And we have actually no ability to do that. And so little things like that about just being honest about that. And I think the same is true if you're an academician at one of those at a transplanter at one of those centers is what do you need me? What do you being very clear about the expectation that you have of your community partner and your community partner raising its hand and saying, hey, I actually think I need some education about this. Can we partner in having that? All of those things build trust. I think in the world of email and cell phones, medical records aren't enough to actually make that human connection to build trust for these patients because they're so complicated. Next slide. And I think that this doesn't just apply to just allogeneic transplant. I think allogeneic transplant, being a good partner when you're the community person, is early referral, involving the NMDP, HLA Today, and HLA Family, which are free services that allow you to type people easier. It's certainly about being engaged in education and communication and really creating a workflow so that when I reach out to Dr. Holtan and say, hey, we're sharing a patient, what's the easiest way for me to get to you? And creating that workflow and sitting down with the institution, hey, we're building shared care amongst us. What does that look like? I think defining expectations is key. If you are not someone who's on your cell phone, then that shouldn't be what your workflow looks like. And having a consensus amongst your practice so that it is concierge service a little bit on both sides. I think both auto and CAR T patients are coming back to you sooner. And so making sure that you're educated, making sure when you need vaccine schedules, the whole goal is to get patients back to living their lives. So they're doing all the adventures that Dr. Holtan was talking about to making sure that they have less financial toxicity, more time with their families. I think especially when you're talking about higher stakes with acute leukemia in regards to allogeneic transplant, I think we can all speak to the idea that we don't know how it's going to go sometimes. We are hopeful, but we don't know. And the more time people are with their family and their friends and the less time are with their doctors, the better for them. So making sure that you're being honest about your capabilities is really key. And I think also too is as the transplanter, asking the hard question of, hey, how quickly does it take for you to get tacrolimus levels? So can you get, all of these specialized studies? Do you have access for your patient to have infliximab in the hospital? And then knowing, okay, then we need to transfer someone. This is our hard stop, and everyone being honest about that. So we're going to come off of camera now, and let's open up the discussion to see what questions all of you have about shared care, about how to build that kind of shared care program, but also too is, what examples you kind of bring to the table and different perspectives that we can discuss.
While we're waiting for others, I'm happy to share a major win recently in terms of shared care. As you know, the FDA has lifted the REMS requirements, and patients post CAR T can go home now as soon as 14, 15 days. We recently have established, I should back up, at Roswell Park, we have a different EHR than pretty much everybody else. And so we can't communicate through Epic like a lot of people do. But we were successful through our legal team in setting up a shared Teams channel with a referring practice that sends us a lot of patients. So we have now a HIPAA compliant Teams channel where we can just shoot messages back and forth about patients. We can share records without having to use the fax machine, the F word, sorry. We have the ability now to have real-time conversations about patients through this Teams channel. And that might be an option for several places going forward. We initially thought, we'd ask and the answer would be no, but our lawyers looked at the proposal and said, actually, this makes a lot of sense. And we have the technology to make this a secure channel, go for it.
Yeah, I will say that we did a clinical trial with Dana-Farber looking at exactly that. And we had that HIPAA controlled channel back and forth, and patients actually had access to it as well. So they could actually be engaged in that conversation and see. I think it's so important for patients to not be the middleman here because they're so complicated to start with. And so creating an avenue where they can be engaged, but know that they don't have to translate what we're trying to say to one another, I think is really huge for patients. I also think it opens up such easy, like, shoot a question of, hey, when did you want that vaccine to start? Can you attach that for me? We'll do it locally, sparing patients needing to drive for, from where I am, it is 4 hours at least to any 3.5 to 4 hours to any major center that does allogeneic transplant. But when you look at the Midwest, some of that is 6 or 12 hours. So being able to kind of tap into the home base for a patient. I also think too, when you're talking about lymphoma, many patients have had relationships with their community partners for years and years. So to then just have to give that up and go somewhere else, I think it's hard on them too. So that's great. I think things like that are really helpful. I will also say too is we have a couple of brochures with both Sloan Kettering and Dana-Farber where we are co-branded. So we can hand it out based on where a patient wants to go. So it looks like we are all part of the same team rather than community partner, transplant partner, leukemia specialist at an academic center. So I think that's another really great way to kind of create this venture together and to open up that conversation.
One thing I guess I can share from our experience here in the Gulf South is it's a little bit more work, but I really love texting. And it's very easy with a lot of, and I'll do it even in the room with patients. The patients love to see it because they love to hear, oh, they're texting my doctor back in Mobile, Alabama, or in Lake Charles, Louisiana, and I'm texting with them as I'm in the room or outside of the room and maintaining those lines of communication. It's a bit more extra work, but rather than just sending a file and a phone call, sometimes I'll text kind of just key points so that the community oncologist is comfortable and can have something to reference and go back to rather than sifting through 50 notes. And so, I think that I really like that. And it also helps when they're back there because what if something happens and, they're trying to call the clinic or get in through the 50 people phone tree to get to you. It's just easier, just a quick text. And I think that's helped maintain a lot of those bridges between a lot of our institutions.
I think someone, and Dr. Holtan, I'll ask you kind of your experience with this. Someone popped up a question is, how do you address the perception that someone's going to be sent to you and then they're going to lose them?
We address that up front. We have a shared care SOP that initiates the handoff for a CAR T or auto as early as day 14, and for allo transplant as early as day 28. We do for sure want our patients, speaking to allo with this patient, we for sure want our patients seeing their home leukemia physician by day 60, because personally, we want patients to be on maintenance therapies, especially those with higher risk disease, and Clark will talk about this later. We want that initiated as soon as feasible, as soon as we have good blood counts and as soon as people are recovered. We do think there's a strong role for maintenance therapies. And so we upfront say, we're going to take care of you through this portion, this very, very intense portion of your care, but we want you to see your team at home. We want you to at least have the discussion about maintenance therapies. And after that day 60, we say, we're going to see you once a month. It can be virtually. And what we are doing is we are monitoring for late effects of transplant, but your doctor is still your doctor. And so maintenance therapies are some of the day-to-day things that may be needed, transfusions, etc., that would be administered locally. We're going to keep an eye on you for our part, and that's in particular graft versus host disease monitoring.
I think also too is it goes back, to answer that question from the community perspective. I think this is where the communication and the workflow really matters. So, Dr. Holtan and I are sharing a patient. I know she's going to send me a message through her secure channel. I'm going to answer that. We're going to be talking. I think that is actually what breaks down the perception that they'll go there and you'll lose them. It is the communication between the two of you. It stops being about us versus them, and just, which is to me extremely silly because it's really about the patient and the person not on the phone call at all, right? But it really becomes about, we are all just different branches of the same tree. I would never, for example, like I would never say to the gastroenterologist, you're not going to give them back to me, right? Like this is just a different specialty and how that works. And so I think it starts honestly with the community provider saying, hey, this is where I'm not comfortable. This is where why you have to go. This is how we share you. So I think having those workflows set and the community partner laying the scene for that makes it a lot easier. And I think I would argue if you don't have the workflow, but you're referring, then I would also argue pick up the phone as a community provider ahead of time and say, hey, I'm sending someone your way. So that like sets the stage of, I have an expectation that after you see them, I'm going to get another phone call. And here's my cell phone because I personally feel as physicians, we should never have to call another doctor's office. It should always, like, it should always be an easy way to get to one another. So I think that's the other way too, as the community partner is, if you set the stage and you make the initiative, I think you will find that that goes a long way with getting the return back for that. Okay, so it's 5:30 and I want to be mindful we have another case to finish up. So Dr. Loren, I'm going to pass the baton to you and let's take it from there.
All right, that sounds great. Thank you. That was a great discussion. And I learned a lot actually, because we have a much more cooperative practice here in Philadelphia. And we share a lot of patients with our community colleagues. Okay, so I'm going to present a case of acute lymphoblastic leukemia. For those of you who are present on the previous two chapters, that patient ended up not going to transplant for a variety of reasons. And so I selected a different case for the purposes of this discussion to sort of set us up for a conversation around maintenance therapies and the use of immunotherapies such as donor lymphocyte infusion. So this also is a real case from my practice, a really tough situation of a young 31-year-old man, very healthy, who noticed some subconjunctival hemorrhages and fatigues, night sweats, weight loss, was sent for labs and had an extraordinarily high white blood cell count, which was almost all blasts. He was referred to the emergency department and then admitted, obviously, with those counts. His bone marrow biopsy showed a markedly hypercellular marrow, almost exclusively composed of CD19 positive, CD20 negative, CD22 subset positive blasts, consistent with B-cell ALL. And unfortunately, his cytogenetics showed a very poor risk translocation, 411 translocation, otherwise known as the gene formerly known as MLL, now KMT2A mutated ALL. And as many of you know, at diagnosis, it's important now to send this clonoSEQ test to identify clonal sequences that can be followed over time. These are individualized to the patient, and so it's important to have an initial sample so that you know what to follow. Quick public service announcement for young patients. You want to think about fertility preservation in men. This is very straightforward with sperm banking. And so that was taken care of as part of his staging. He had a lumbar puncture with no blast, but it was thought that he had on exam leukemic retinopathy, and his testicular ultrasound was negative for any masses. Continue, please. He was treated on a pediatric-inspired protocol. Obviously, 10403 is no longer open, but this is sort of the backbone model that we use when we don't have a clinical trial available. After his initial induction, he had a morphologic remission, but was still flow MRD positive, and proceeded to course 2 of induction. Unfortunately, he had an allergic reaction to PEG asparaginase and was switched to the Erwinia-derived compound, which he tolerated well. His marrow, after completing the second course of induction, continued to show a morphologic remission. He reverted to flow MRD negative, but still had detectable clones on his clonoSEQ testing. And so at that point, he was referred for transplant evaluation. And we'll talk more about this, but obviously with the KMT2A mutation, which confers a very poor prognosis, even with pediatric-inspired protocols, an allotransplant was an appropriate consideration. He actually had a matched sibling donor, and so we were ready to go for transplant. He received a course of blinatumomab to try to optimize his remission, and also to give us time to work up the donor and complete all the testing and insurance, et cetera, to get him ready for transplant. His first cycle of blina, he actually developed cytokine release syndrome, which was treated and resolved. His next marrow before transplant continued to show some clonoSEQ clones, but these were decreasing in number and size. And so we felt good proceeding with transplant. His donor was his 34-year-old brother, HLA matched. We used a bone marrow graft for CR1 to reduce the risk of graft versus host disease in the future. It was a CMV positive to positive transplant, and you can see ABO incompatible as you, ABO compatible transplant as you see here. Donor was A pos, recipient was AB pos. Okay, and so first polling question, what are the indications to proceed with a transplant for a patient with Ph-negative B-cell ALL in CR1? So many of you know that the advantage of a pediatric-inspired protocol in young adults is that there's a substantially higher rate of CR, which obviates the need for transplant in many patients, but not all. And so if you can indicate which of these features would indicate to you that the patient needs a transplant. I think it's certainly convenient to have a matched donor, but I wouldn't allow that to determine the indication for transplant, particularly now that we know that 7 out of 8 matched donors with the PT-Cy-based graft versus host prevention regimen likely yields equivalent outcomes to an 8 out of 8 matched donor. So I think availability of a donor is obviously necessary, but not sufficient to indicate transplant eligibility. But the other 3 I agree with. So any suggestion that there's persistent positive disease, and certainly the poor risk KMT2A mutation is our key indicators for transplant. Okay, continue. Oh, I think this ended up being a little bit out of order, but in any case, what would make you think about a donor lymphocyte infusion in a patient who has received an allogeneic transplant? And again, you can choose all that apply. Okay, great. Yeah, so actually all of these except for treatment of GVHD would be appropriate indications for DLI. And so many centers, including ours, will offer DLI. We actually use an escalating dose approach similar to the old data for CML molecular relapse, because it seems that there's a lower risk of GVHD if you do it in a graduated dose fashion for incomplete donor engraftment. Certainly disease recurrence is probably the leading indication for DLI, and for that we use full dose DLI without fractionating it. And actually infections including EBV would also be an indication to consider DLI. There was very close to FDA approval an EBV-directed DLI product that unfortunately has been delayed by FDA, so we don't have that to use yet, but hoping that there will be progress in that regard. But certainly using DLI to treat severe refractory infections is a rare but very appropriate indication for DLI. Okay. So for this patient, he was in a morphologic remission. He was flow MRD negative, still had a persistently positive clonoSEQ test. The patient himself was young and healthy with really favorable transplant risk profiles based on his HCT score. He actually had 2 HLA matched siblings, a brother and a sister, which is quite fortunate. We chose the brother due to significant data showing that a male donor confers a lower risk of GVHD. And our center's practice is to use a TBI-based myeloablative regimen for a young, healthy patient with a lymphoid malignancy. So he got a cy-TBI bone marrow graft from his HLA-matched brother. We have not gone to using PT-Cy for myeloablative transplants in the absence of large randomized trials that may be changing. And there is some emerging randomized trial data coming, but I think that we still have been reluctant to pursue that largely because we still use pretty intensive alkylator-based regimens for our conditioning for myeloablative, and we have some concerns about the toxicity of ongoing alkylator post-transplant. So interested in people's thoughts about that. But moving forward, that's what this patient got. He actually had a very smooth transplant. He did great. He had very high early engraftment. We had planned an early bone marrow biopsy at day 60 and then had considered putting him on preventative revumenib for his KMT2A mutated high-risk disease. Unfortunately, he had a very early, very aggressive relapse. On day 49, he presented to clinic with a white count of 100,000 with circulating blasts. Recurrent 411 translocation. He actually required emergent admission for cytoreduction with steroids and cyclophosphamide and then revumenib. He had sort of a marginal response to that. We added aza-ven because he actually underwent a lineage switch and started developing some myeloid surface markers. After his first cycle of aza-ven revumenib, he developed clonal evolution of his leukemia and was starting to lose his graft. Next slide. And we gave him a second cycle because it seemed like he was responding, and then DLI sort of at nadir with lowering levels of disease. In general, we prefer to give DLI when people are in remission because we feel that the donor immune response has a higher chance of effectiveness when the disease is in low disease state as possible. But we really felt like we sort of had a very small window to give this to him, considering how hard it was to control his disease. And unfortunately, he has progressed through DLI. He's now managed primarily back with his leukemia team. They're continuing revumenib, and we're planning to start inotuzumab as salvage therapy. So really tough case. So on that positive, we should have done it the other way around with Shernan's case being the happy one. Next time we'll have to think about it that way. Anyway, so tough situation. And I'm just going to hand this off now to Dr. Alsfeld to talk about the role of maintenance post-allo transplant. Thanks.
All right. So I would love to talk for the next 12 hours about maintenance treatment, but we don't have that kind of time. Nobody does. So I really tried to highlight just a few, I think, key trials. And I think the big picture view here is really to highlight the fact that there is some very impressive data for the use of maintenance therapy. And if you look at what's the most impressive complication post-transplant still to date is relapse. And so how do we mitigate that risk and how do we improve upon that to allow for better outcomes? Because there's nothing more devastating. I think everybody in this call can agree that nothing more devastating than having gone through a transplant and then relapse and having to restart that race. And so I highlighted just a few trials here in a few key areas and some good data. There's also some controversy here. So I think for me, it's really important to have very open conversations with our patients when we're entering this phase of their transplant journey, and just trying to be a resource for them, and especially in partnership with a community oncologist, so everybody's on the same page. So I'm starting with just the FLT3 inhibitors because I think there's a lot of great data here. The first, sorafenib. Sorafenib, most of us are probably well aware of it. The first trial was a SORMAIN trial. And it looked at sorafenib 400 milligrams twice daily, and it was continued for 2 years and showed an improvement. So there was a reduced risk for relapse and death, improvement in 24-month relapse-free survival and 1-year relapse. There was then a longer-term study out of China that looked at 5-year survival data and also showed an improvement in overall survival, leukemia-free survival, and Griffiths, which is GVHD relapse-free survival. And so I think sorafenib then has a very clear role in maintenance therapy for FLT3 mutated. It's worth noting that in both of these trials, dose reduction was necessary. I think it was 48% in the SORMAIN trial and 60% in the long-term trial out of China. So be mindful of this as they're entering back to the community of what adjustments may need to be made to the sorafenib dose. A more recent trial for gilteritinib, another FLT3 inhibitor, was a Morpho trial, the BMT-CTN 1506 trial. And this was designed for 2 years of gilteritinib, 120 milligrams versus placebo. It did show an improvement in relapse-free survival, but the problem was it wasn't statistically significant. It was close. But then when you look at a subgroup analysis of patients who were MRD positive, so either MRD positive pre or post-transplant, there was a statistically significant improvement in relapse-free survival. So I think gilteritinib certainly has a role in the maintenance setting, probably stronger argument to be made if they're MRD positive peri-transplant. And I think this is a commonly used drug for maintenance therapy in FLT3 mutated AML. Touching on some smaller studies with midostaurin, there was the AML-SG 1610 trial. It looked at midostaurin 50 milligrams BID for 12 cycles, so for 12 months. When they compared it to historical controls, there was an improvement in event-free survival. There was then a follow-up study, the RADIUS trial, which also looked at midostaurin maintenance compared to the best supportive care or standard of care options. And it did show an improvement in that trial as well in relapse-free survival, but it wasn't statistically significant. So I think there's certainly an argument to be made for any one of these FLT3 inhibitors. And then the most recent study was a meta-analysis that looked at 4 trials, including sorafenib, gilteritinib, midostaurin, and looked at these trials and looked at the survival benefit, and relapse-free survival was there for both FLT3 inhibitors when you used any one of them. So I think the meta-analysis to me really kind of puts it all together and looks across all the FLT3 inhibitors and says and really confirms that yes, there is a benefit to FLT3 inhibitors after transplant. You do have to be mindful in this trial, this meta-analysis, they did see, of course, hematologic toxicity, again, as we know in the other trials. So really important to keep that in mind, that dose adjustments are frequently needed. And then there was a very, very slight increase in the pooled analysis for chronic GVHD, which was very minimally increased. But I think across the board, FLT3 inhibitors have pretty good data here to support their use as maintenance therapy post-transplant. Hypomethylating agents, as Shernan talked about before, really, I think a lot of data out there. A couple just to highlight. The first is what NCCN guidelines reference. There's a trial by Gao and his colleagues out of China. They looked at GCSF plus decitabine use, and they used decitabine at 5 mg per meter squared for 5 days with concurrent GCSF use. And in that trial, those patients did have an improvement in 2-year cumulative incidence of relapse. You see 15% versus almost 40%. There was then a meta-analysis looking and pooling 14 different trials using HMAs and also showed an improvement in overall survival and relapse-free survival. So I think, there are obviously some nuances within all of these trials. NCCN has the GCSF decitabine listed just slightly differently. I think there are a lot of differences within the HMA trials. So a meta-analysis, of course, there can be some controversy there. But to me, this gives it an option, especially in patients with high-risk AML, as Gao and his colleagues used to define for qualifying for that trial. So I think hypomethylating agents, certainly something, as Shernan had mentioned, to consider and really just highlighting some of the discrepancies that may exist there. Switching to the other side of the court, ALL, I think frequently used are the tyrosine kinase inhibitors. There are plenty of trials out there, and I really just picked 3 that jump out to me. First was the GMAL study, and what they did is they looked at prophylactic versus MRD triggered. So just starting it out the gates versus monitoring MRD and starting imatinib post-transplant. And what they found was prophylactic usage, so starting it just preemptively, allowed for lower molecular recurrences versus MRD triggered. If you look at the survival curve there, 5-year survival, 80% versus almost 75%, not statistically significant, but still really good numbers. So I think that really highlights that maintenance therapy using a TKI, in this case, imatinib, is beneficial. There was a retrospective analysis by EBMT looking at many different TKIs. Primarily, they looked at imatinib and dasatinib and found that TKI use was improved, did improve the overall survival, leukemia-free survival, and reduce the risk of relapse. And then lastly, there was a prospective study more recently that looked at preemptive. So they worded preemptive if they were MRD triggered versus prophylactic. That prophylactic group was a historical control, and they looked at imatinib, dasatinib, nilotinib, and ponatinib. And in the preemptive, so in patients that were MRD triggered, there was a starting a TKI at that point, improved the cumulative incidence of relapse of 11% versus 31%, again, in historical controls. And then the 3-year overall survival also favored MRD triggered usage, as did the leukemia-free survival. It's a little bit different than what the GMAL study showed, but I think what this highlights is that however you use it, maintenance TKI therapy certainly has a benefit in Philadelphia positive ALL. So a couple key points and future directions. Key points, again, FLT3 inhibitors, yes, I think they're beneficial. Which ones? I think you could make an argument for any one of them. I didn't mention here quizartinib, but another one to consider. The question is how long? Well, in the trials, 2 years was what was studied. I think in many different settings, you could make an argument one or the other for duration, but I think keep in mind dose adjustments in these patients need to be made across the spectrum, both in the academic and community setting. Hypomethylating agents, absolutely, as Shernan had highlighted, the meta-analysis certainly shows support for that. How long? Most people do about 2 years. I think I left it pretty open for interpretation. And then for the BCR-ABL TKIs, I think whether you use it prophylactically or based off of MRD, I think you could make an argument either way, but continue at least for 2 years. Some centers say 5 years. I think that's still an area of debate. I think what's really exciting, so we talked about hematologic toxicity and some of the challenges that I've found, and I think many of us can agree to this. One of the challenges post-transplant is keeping people on treatment, and the hematologic toxicity can be a real bear to deal with. These newer drugs, so the IDH inhibitors, IDH1, IDH2, more importantly, menin inhibitors, with much less hematologic toxicity, really are showing a lot of promise, and I think it will be exciting to see as more data is available how this field moves. And of course, azacitidine and venetoclax, the VIALE-T trial, waiting on that information to see how that may shift maintenance therapy. So I think I wanted to open up and just kind of see what others do and how people approach maintenance therapy. Is it directed by the transplanter? Is it directed by the leukemia team? Is it directed by the communoncologist? How does everybody do it at their respective centers?
Yes, I can just kick it off by saying that, for us, I think a lot depends on the indication. If patients are relapsing, we usually keep them here. But if it's purely a maintenance strategy and the patients are doing well, almost everybody prefers to get treated closer to home. And so we sort of have a shared care model with a lot of communication. One thing that's helped us, and I'm sure every place is different, but Penn has a lot of sort of our practices in the community. So we are on a shared medical record. We can secure chat each other. It's very easy to collaborate in those practices. And so that's another kind of aspect of taking down barriers, is when you have an explicit relationship with those practices. I recognize those decisions are way above all of our pay grades in terms of whose relationships are established that closely, but that is helpful.
I'll second the shared care model for maintenance. And I'll also throw out that I think PT size should be standard for anyone, regardless of conditioning intensity. I know that we still need randomized data, but I'm going to throw in the chat a large phase 2 that we did in myeloablative transplant in Minnesota, almost all patients got TBI alone, followed by PT-Cy, very well tolerated. And then currently for a non-TBI based regimen, we're really liking thiotepa, busulfan, fludarabine, and we'll use that with PT-Cy in the myeloablative setting and not having any concerns with toxicities.
Yeah, no, that's a very fair point. I know there was a randomized trial from Australia that was published in the New England Journal about 6 months ago, which also is sort of pushing us towards changing our practices. We're in the process now of really evaluating that and just changing over. We also have not, probably shouldn't be outing ourselves, but we have not yet moved to like a fludarabine-based myeloablative regimen. We used to use it usually either Bucy or Cy-TBI, and so thinking about should we just upgrade all of our regimens, think about treosulfan, et cetera. So we've been sort of like trying to marshal our forces about just sort of a programmatic change and how many things to change at once. But I do think that there's accumulating evidence that we should be moving in that direction.
The benefits of a smaller program, we can make changes a little easier.
Yeah, I will say it was convenient during the fludarabine shortage to have a set of regimens that weren't touched by that.
We'd be in trouble. Yes.
Yeah, as most of us would be. Any comments from the attendees about your experiences with sharing care in these complicated scenarios, post-transplant maintenance, therapy, coordinating DLI? That's always challenging. When are they ready? Well, when will the donor be able to donate? That's obviously a lot of coordination as well, figuring out the timing of their therapy versus their DLI. I see a question in the chat. How do you adjust maintenance therapy in between with preemptive DLI? Any new toxicity signals? So I think when you're talking about preemptive DLI, I think what you mean by that is, I'm not sure what you mean by preemptive DLI. I guess, can you describe the scenario that you're thinking of if you're able to add that to the chat? I think of preemptive DLI as either after a very low intensity regimen, planned DLI, or CD34 selected transplants followed by planned DLI, or for incomplete chimerism, more of a, I guess it's preemptive in that sense.
Yes, I would ask
low-level disease or high-risk disease relapse.
Yeah, is the question whether therapy needs to be held for DLI? So if someone is getting a TKI or a hypomethylating agent, we are dealing with maybe a low-level relapse situation. Does that therapy need to be held in order to receive DLI?
Yeah, I think I don't think anybody knows the answer to that question. Thinking through it biologically, if they're relapsing through their maintenance therapy, they're probably not responding. And so clinically, I think the decision I would likely make is to discontinue that maintenance therapy, give the DLI, and then think of a different strategy post-DLI or not. DLI is supposed to be definitive therapy. And so hopefully the cellular therapy that you're giving is going to take care of that low-level disease relapse. But I think it really comes down to sort of your judgment and your impression of the patient's risk and how they're responding to the therapy you're offering.
I will also say too is, and maybe this is part of what they're asking is, I had a patient who we were doing, like a week of Vidasa-Ven, and they were on Ven for 2 weeks, and then would get DLI, week 4, and then immediately back. And so I think that's a great example of shared care and coordination. Like I would say, they're like, when is he getting his next cycle? And I was like, oh, I had to delay it 2 weeks because of his pancytopenia. And they were like, okay, so let's plan for every 6, and then you shift back and forth. And so in those scenarios, are there any additional toxicities when you're intercalating it, I guess, in between the maintenance that you're worried about in regards to pancytopenia, infection, et cetera? I'm wondering if that's what the intent of that question is.
Dr. Holtan, what do you think?
I think I don't think we know, as you had mentioned. My personal feeling generally is that we don't have to be super precise about the timing of DLI when we're dealing with HMA or other drugs. I think that the only time we need some precision is if we're giving conventional chemotherapy. We could time the DLI after that. You don't want to give DLI and then give conventional chemo potentially. It could be killing the lymphocytes, but gosh, HMA probably doesn't hurt the DLI, may even help. So I don't think that we have to be so precise with the timing of these things. We can really make it work for the patient.
Yeah. I do worry about venetoclax. It's BCL2 inhibitor. Again, we really just don't know. We have 1 minute left in theory, and there's a question in the chat about, as the pharmacist, what kinds of questions should you ask for a B-cell ALL patient who's responded to Blina? If it's all right with you, I'm maybe going to put a pin in that because I know Ankita has a presentation about late transplant care that I want her to be able to talk about, and then maybe one of us can try to follow up with you about your question.
Yeah, I think that sounds great. And that was a really good question. So we'll make sure to follow up back with you, Elizabeth. So we are at time, but feel free to stay because we do have a couple more slides, but I'll try to breeze through them as quickly as I can. So we did chat a lot today about some of the different post-transplant complications and things that we would want to look out for within this period, especially since patients are transitioning back into their communities. And it really requires this shared care model where the hemonc provider who initially referred that patient has awareness of these considerations. And we definitely don't have time to go over all of these because there's just so much to say about it. But we do have some post-transplant guidelines that I will share with you in a little bit that you can actually download to your phone and can hopefully be used in those clinical moments of need. So chronic GVHD is a complication of stem cell transplant that can affect a variety of different organ systems, and typically it presents between 3 months and 1.5 years post-transplant, though it can occur later. So it remains an important thing to sort of keep on the differential list for these patients, especially since prompt recognition and treatment are so critical to preventing permanent complications and optimizing those outcomes. And then obviously we talked about, balancing the risk for infection in this period is also so important. And so, there's a lot of things that we're considering, especially with these patients that have just experienced profound immunosuppression happening with conditioning regimens and that gradual recovery of the donor immune system. And with that said, there's obviously the discussion of implementation of a vaccine schedule after allotransplant, which is really carefully timed to ensure that we're balancing, when that immune reconstitution is happening with the infection risk for the patient. So these are some of the recommendations that are outlined within guidelines, and you'll see that certain vaccines here start earlier, so like as early as 3 months, whereas the live vaccines, which are a little bit more risky, would start a little bit later. You can go to the next slide. And when we look at secondary cancer risk post-transplant, it's really important to consider that these patients have a 2 to 3-fold increased risk of developing secondary malignancies compared to the general population. So screenings just become so essential to really ensure that, again, prompt recognition is happening. Go to the next slide. And then patients who receive allotransplant also have an increased risk for organ toxicities. They've gone through so much treatment that can be quite damaging. So screening and awareness around this is, again, so crucial. If you go to the next slide, we can talk just quickly about our post-transplant care guidelines. So, the care of these patients is so nuanced and no one is expected to memorize all of these things. So the NMDP and the ASTCT came together to publish post-transplant care guidelines to really help make this process easier to access. So if you go to the next slide, you'll see that it's basically broken into 3 parts. So we have long-term screening, vaccination schedules, and then screening for chronic GVHD. And what I love about these guidelines is there's actually a photo atlas, which is really helpful to kind of see those clinical manifestations when you're seeing those patients in real practice. And if we go to the next slide, you'll see the instructions for downloading the app. So this is kind of something that you can keep in your pocket on your phone. There is an app called Transplant Guide on your app store, and it's free to download. And again, in those clinical moments of need, I think it could be really helpful when you have a patient in real time. So I'm pleased to share with you some of our free resources that the NMDP has for you and your patients. The NMDP's mission is really to save lives through cell therapies. They've been doing transplants for a very long time, since 1987, have been helping to facilitate transplants throughout the country. And we have covered today how coordination of care is really essential to getting these patients to and from hemonc practices and transplant centers smoothly, and the NMDP can help build those partnerships and processes and really partner with you. If you go to the next slide. So these are kind of like a portfolio of different resources that we have available through our Pathways to Transplant program. And I'll just highlight here, you'll see in purple the Age Late Today program, because that really is our prime offering within this program. And it's free typing for patients who do not have access to HLA typing in the community. And we know this is just such an essential step to getting the donor search started for a patient and really preventing any delays in transplant. So if you go to the next slide, the HLA Today program, again, it offers free and fast typing. There's no cost associated. There's no insurance paperwork associated. And it really helps to ensure that that early donor search is happening really early on in the process, so that at the time of first consult with the transplant expert, the transplant center already knows what the patient's donor options look like. So we provide swab kits for patients and family members at the hem-onc practices, and NMDP delivers an initial search summary report to the transplant center and the hem-onc provider. And if you are interested in more information about this, please just email pathways-to-transplant@nmdp.org. We also have a lot of great resources through Blood Cancer United. So they offer blood cancer specific information and support resources for patients and caregivers, including rare blood cancers. Education formats include telephone and web programs, videos, podcasts, and booklets. An example of the ALL webinar displayed on the slide, and tomorrow is actually a live webinar on nutrition, and it goes over pre and post auto transplant nutrition. Each of these will also be recorded and available on demand. Blood Cancer United also has information specialists that are highly trained oncology social workers and nurses who provide disease, treatment, and support information, including financial help. Patients can actually contact them or complete a referral form for your patient, and these information specialists can help access or order multiple free copies of booklets for you at no charge to give to patients and really help find and order any resources on today's slides. They also have registered dietitians who can provide free nutrition consultations via telephone, and clinical trial support center nurse navigators who work one-on-one with patients by phone to provide user-friendly information to really help understand clinical trials, find clinical trials, and provide information about that and bring it back to the healthcare provider. Navigators are also working directly with healthcare providers, and the goal is not to enroll every patient in a trial, but rather to just provide information, understanding, and options. And links to financial assistance programs are listed as well. For you, CE and CME accredited online and in-person programs, a targeted podcast channel, videos, and fact sheets provide updates and treatment strategies for patient care. There's also live webinars that are recorded and offer accreditation. So if you miss one, you could still access it on demand. Some of the examples of a few different topics that they've had are displayed here on the slide. So we hope that you will consider all of these resources and the specialists at Blood Cancer United as an extension of your team. Thank you for being here. Thank you to the faculty for hosting such a wonderful discussion today. Thank you again, and I hope everyone has a wonderful evening.